All right, let's jump right into this explainer. I want you to picture this. We're walking the halls of the hospital on morning clinical rounds for internal medicine. I'm the attending physician, and I'll be guiding our resident through a pretty complex new admission. We're going to use the Socratic method today, which means lots of questions. Our goal is to deeply understand congestive heart failure, not just as some dry textbook concept, but as a living, breathing patient who's sitting right in front of us.
Here is our rounding list for today. We're mapping out our journey from the moment we meet the patient at the bedside, unraveling the underlying mechanisms, running through the diagnostics, and finally formulating a solid treatment plan with guideline-directed medical therapy. Section 1. Meet the patient. Let's step into the room.
Our resident starts presenting the case. We've got a 64-year-old man, and his chief complaint is severe orthopnea and really pronounced leg swelling. He actually tells us he's currently sleeping on 3 pillows just to catch his breath. And his dyspnea, it's worsened from just happening during exertion to happening even when he's resting. Now, crucially, he reports a rapid 5-kilogram weight gain over just the last 2 weeks. When we look at his medical history, it's honestly a perfect storm of cardiovascular risk: poorly controlled hypertension, a prior MI, type 2 diabetes, and a significant smoking history. So I turn to our resident and ask my first question. Based on this history of orthopnea and massive fluid retention, what specific physical exam findings must we look for right here at the bedside to actually prove our patient is congested? The resident absolutely nails it, rattling off the critical physical exam findings. They highlight the bibacillar crackles in the lungs and the 2+ pitting edema going all the way up to his knees. But I really want us to focus heavily on 2 specific things here. First, the elevated jugular venous pressure, or JVP, which is basically a direct barometer for right heart backup. And second, the presence of an S3 gallop. That's the audible sound of blood rushing into an already overloaded, super non-compliant ventricle. We also note his blood pressure is running high at 148/92, and he's tachycardic with a heart rate of 104. Moving on to Section 2, Mechanisms of Heart Failure. Okay, we know what the patient looks like, but what is the pump actually doing? I asked the resident to categorize this failure using the 5 really useful dichotomies of heart failure. Is it left-sided or right-sided? Forward, low perfusion, or backward congestion? Systolic or diastolic? Low or high output? And finally, is the ejection fraction reduced or preserved? The resident correctly anchors our patient's presentation primarily to backward left-sided failure. That's what's causing the pulmonary congestion, which then backs up to cause the right-sided failure and leg swelling. But what caused all of this? We run through common etiologies. Our patient's failure is likely driven by his prior ischemia and his hypertension. But as a rule, we always have to keep things like valvular disease or even alcohol use cardiomyopathy on our differential. Now I push the resident a bit further to explain the structural differences. They correctly define the 2 main morphological types. We have HFpEF, heart failure with reduced ejection fraction, which is characterized by a dilated, thin-walled, totally weak ventricle that just can't contract effectively. And then we have HFpEF, heart failure with preserved ejection fraction. That's where the walls are super thick and stiff, the heart contracts fine, sure, but it can't relax and fill properly. To truly grasp how we're going to manage this, I challenge the resident on some fundamental hemodynamic concepts. We need crystal clear definitions here. Preload is the volume and pressure stretching those ventricles right before contraction. Essentially, it's all that fluid backing up in our patient right now. Afterload, on the other hand, is the systemic arterial resistance that the heart has to squeeze against to push blood forward. In a failing heart, decreasing that afterload and optimizing the preload are literally our primary levers to restore cardiac output. And this brings us to the physiological trap our patient is currently stuck in. The heart is failing to pump forward effectively, right? Well, the kidney sense this low forward flow and decreased perfusion, and they completely hit the panic button. They literally think the body's bleeding to death or severely dehydrated, so they initiate this massive, powerful compensatory mechanism.
The resident seamlessly explains how this triggers the RAAS cascade, the renin-angiotensin-aldosterone system, and the ultimate result of that? Massive systemic vasoconstriction. This spikes the afterload, making it even harder for that already weak heart to pump. Simultaneously, aldosterone forces the kidneys to aggressively hold on to sodium and water. This vicious cycle directly explains our patient's rapid 5-kilo weight gain and his skyrocketing venous pressures. The body's frantic attempt to save itself is actually drowning the heart. Crazy, right?
Section 3, Bedside Profiles and Diagnostics. Back at the bedside, we have to translate all this complex pathophysiology into a functional real-time profile so we can actually do something. The resident summarizes the Stevenson bedside profiles. It's a really elegant way to assess a patient in literally 2 minutes. We just ask 2 questions. 1, are they congested, meaning wet?
We look for that elevated JVP and S3 gallop. 2. Are they adequately perfused, meaning warm or cold? If they were cold, we'd see a narrow pulse pressure, cool extremities, maybe low urine output. Our patient is decidedly wet, and thankfully still warm.
So, we have our bedside profile, but I turn to the resident once again. How do we confirm our clinical suspicion objectively? What is our actual diagnostic workup here?
The resident quickly lists the critical tools in our arsenal. We start with a 12-lead ECG, looking for Q waves that would indicate his prior infarct, or signs of left ventricular hypertrophy from all those years of hypertension. Next up is the BMP or NT-proBNP blood test. This is an incredibly sensitive test. If it's normal, we can almost certainly rule out heart failure. And finally, the gold standard, the echocardiogram. This lets us actually visualize the pump. In our patient's case, the echo confirms exactly what we suspected. He has a dilated left ventricle with an ejection fraction of just 30%. He officially has HFrEF.
Section 4, classifying the failing heart. With the diagnostic data in hand, we have to accurately label the severity of the disease to guide our long-term therapy. The crucial point to remember here is blending two completely different classification systems. On one side, we've got the NYHA functional classes, from I to IV. These are entirely subjective, based on the patient's symptoms and exercise tolerance. Our patient, who is gasping for air even while resting, is firmly a class 4. On the other side, we have the ACC/AHA stages, A through D, which track the objective structural progression of the disease. By combining these two systems, we get a really complete clinical picture that dictates our strategy.
Section 5, managing acute decompensation.
But before we can talk about long-term strategy, our patient is actively struggling to breathe right now. We need an immediate acute plan. The resident rapidly walks through the LMNOP acronym, which is the classic framework for treating acute heart failure decompensation. L is for Lasix, the IV loop diuretic that's going to help him pee out that extra 5 kilos of fluid. M is for morphine, though a quick aside, we use that much more sparingly today. N is for nitrates. These act as potent vasodilators to rapidly reduce preload and ease the burden on the heart. O is for oxygen, giving him necessary ventilatory support. And P is simply positioning him upright, letting gravity pull that fluid right out of his pulmonary vasculature. Section 6, 4 pillars of GDMT. All right, fast forward a few days, the LMNOP protocol worked beautifully, and our patient is fully decongested. Now we must look at long-term survival through the 4 pillars of guideline-directed medical therapy, or GDMT. This is the absolute bedrock of long-term HFrEF management. You see, these aren't just symptom relievers. These drugs actually reverse remodeling and save lives by blocking that disastrous RAAS cascade we discussed earlier. The 4 pillars are an ARNI, ACE inhibitor or ARB, a beta blocker, a mineralocorticoid receptor antagonist like spironolactone, and an SGLT2 inhibitor. We are going to systematically titrate our patient onto all 4 of these life-saving therapies before we even think about discharge. Well, we've successfully rounded on our patient today, but as we step out of the room, I want to leave you with one final provocative thought. We just spent this entire explainer discussing how to aggressively block the body's own, yet totally flawed, physiological responses to a weak heart. But looking ahead, will the future of cardiovascular medicine be finding advanced therapies that actually regenerate the myocardial tissue and fix the root cause? Or will we eventually just abandon the biological pump altogether in favor of advanced mechanical devices? It's definitely something to chew on as you continue your clinical journeys. Thanks for rounding with us.